Hello, Liu. Professor Hyodo,
Yes, hello.
welcome. So good to see you. Thank you very much for joining.
Again.
Today's hosts and co-hosts are Dr. Ben and Dr. Sachin. They'll be joining us soon, I hope. Liu, can you hear us? The second speaker has already joined. Dr. Kiran.
Hello, Professor. Hello.
Hello.
Hi.
Professor Koyama, so good to see you after a long time. How are you?
Hello. Good, how are you?
I'm fine, thank you, Professor. Nice to see you.
Nice.
Professor Carter has joined us. Hello, Professor Kato.
Hi. Hi.
Hello,
Hi.
ma'am.
How are you?
I'm fine. Konbanwa, sensei.
こんばんは。はい。兵藤先生、こんばんは。
はい、こんばんは。
お元気ですか？
まあ、とりあえず元気ですよ。今
小山先
沖縄なのよ、今。
あ、そうなんですか。長崎のあれ、ありがとうございます。
いや、
はい
昨日長崎で、
はい
今日移動して沖縄に来ました。
沖縄で何やってんですか？
いやいや、だから明日一例やって帰る。
ああ、
うん
兵藤先生 is now in Okinawa. He's going to treat the patient. It's more Okinawa, some hospital, I think. 小山先生、こんばんは。
どうもこんばんは。お世話になってます。
はい。いや、お世話、こちらがなっています。ありがとうございます。今日はありがとうございました。はい。Good evening, Harry.
Hello, hello, Professor.
Everything fine for you?
Yeah, all good.
So, Raja, yesterday was it was a great the webinar. Unmute, please.
So can you
Sorry.
tell me who is the first speaker and what is the presentation?
First speaker, Hyodo Sensei.
はい。
Oh, I see. Okay.
So,
Professor Hyodo will talk about the aneurysm treatment, right?
Yes.
Okay, thank you.
New
Is there
concept.
a second speaker?
Second speaker is me, Professor. I will talk about endoscopic evacuation of ICH.
Okay. Thank you.
so Dr. Ben has joined us. Hello, Ben.
Hi, man. How are you?
Hello, nice to meet you, Raja. Nice to meet you, Kato Sensei.
Hi, how are
Just
you?
finished the emergency.
How are you?
Thank you so much for
Hi.
getting me to moderate this section. And nice to see you all.
Thank you very much. So now when are you already the board the neurosurgeon now, or are you going to take an exam, Ben?
Yes, I'm already a board neurosurgeon. Yes, and I finished the exam 1 year ago, and then now is associate consultant in my unit. So my main specialty of interest would be skull base and also vascular. So nice to learn from master like all of you guys. So it's still the beginning of my career, and I really enjoy participating in the ACNS to learn more about the neurosurgery.
Yes, please. You learn the notes every time.
Thank you so much.
Hi. So maybe I think Dr. Liu.
Liu?
Yes, hello, Raja. Hello,
Hi,
Professor.
Hi. So I don't think Dr.
Hi,
Sachin, maybe that you can start, please.
Dr. Ben is there. Dr. Ben, would you like to introduce our chair and speaker?
Yes, definitely. So maybe shall I start now? So good morning, good afternoon, good evening, everyone, and thank you so much for joining the ACNS YNS webinars. So today we have Chair Professor Naoya Kuwayama Sensei, who is the Deputy Administrator of the Hospital Director of Neurovascular Center, Toyama Red Cross Hospital in Japan, one of the renowned center for endovascular treatment. So today, our expert speaker would be Akio Kuroda Sensei, whose topic would be the endovascular treatment of cerebral aneurysms, the new concept and including what's expected during direct surgery. And also our second YNS speaker would be Dr. Hakurin, who will be speaking about the endoscopic evacuation of ICH and introduction to young neurosurgeons. So may I invite our chair, Professor Kuwayama Sensei, to introduce our first expert speaker. Professor Kuwayama Sensei, please.
And before Professor Koyama say something, I would like to introduce Koyama Sensei. The Koyama Sensei used to be the endovascular Japanese, the endovascular the board exam, the chairman. So just he finished his role, but he's really brilliant, the endovascular neurosurgeon in Japan.
Thank you very much. Thank you, Professor Kato, to introduce me. And so today we invited Professor Hyodo. He will speak about the most updated data about the endovascular aneurysm treatment. Is Professor Hyodo, are you here now?
Yes, I am.
Okay, are you ready?
Yes, actually, I'm ready.
Okay, thank you very much. Let's start your lecture.
Dick Sensei?
Can I start?
Yes, of course.
Okay. So this is my slide.
Sorry, Hyodo Sensei is a teacher of the Tamura Sensei.
Hello, Professor.
And also, Professor Hyodo is my teacher. Maybe 30 years ago.
Okay.
In the university at Tsukuba, University of Tsukuba. Yeah.
Everybody see my slides?
Yes, we can
right?
see your slides.
And everybody can hear me?
Yes.
Okay.
All right.
Thank you very much, Chairman, Professor Kuwayama, for great introducing me. Actually, I'm a teacher of you, but it means, I'm very old anyway. So today, I like to give a lecture about the endovascular treatment of cerebral aneurysm. It's a kind of new concept compared with the old concept. And additional, including what is expected doing direct surgery right now. Okay, so this is the 47th year after graduate from Chiba University School of Medicine for myself. It means, of course, a little bit, after retirement already. So it means very old. But so far, my subspecialty is for the treatment of cerebral vascular disease. And, for a long time, both neurosurgical and endovascular surgery I did. It's a so-called hybrid neurosurgeon. So far, I have performed neurosurgical operation about 2,000 cases. And after retirement to chairman professor of neurosurgery, 5-6 years ago, only endovascular surgery I have done, but still doing. So far, neuroendovascular treatment is about 6,000 cases. So this is my annual procedure, participated the cases. The pink dot indicate the endovascular surgery, and the blue dot indicate the direct surgery. So, you say, you see, after 5 years ago, the direct surgery is 0. But still doing endovascular surgery yearly, maybe 250, or last year, more than 300. Still doing. But doing means, not done by myself only, and just participate. And also, with young doctors, so how to do that, I tell you. So this is annual surgery. Pink dot also the endovascular surgery. The recently more than 150 cases, but clipping is quit 5 years ago. But so far, I have done about 800 cases of direct surgery, and instead of that, the direct endovascular surgery is almost 3,000. And so let me talk about the endovascular treatment of cerebral aneurysm. So compare with the new concept, what is old? So old means it's traditional method is a coil embolization. It means a coil packing into the aneurysm sac as tight as possible. So like this, just insert the microcatheter inside the aneurysm dome and put the coil as much as possible and detach, and that's it to make a tight packing. So it began, invented by Professor Guido Guglielmi with Fernand Vignola in UCSF in the United States. And in 1991, he presented a paper to the Journal of Neurosurgery. Everybody knows about that. So, instead of clipping is from outside, the coiling is from inside, the inside the aneurysm, the making to inside the coil as much as possible, make a tight packing. If the neck is a little bit wide, put a stent or balloon. So it's a kind of assist technique. So, this paper, everybody knows as the ISAT study. 2002, they are presented in the Lancet. Compare with the direct surgery and, endovascular surgery for the ruptured aneurysms. The result is, the endovascular surgery is, superior to the direct surgery. So after that, the many European countries compare the treatment policies dramatically changed, shifted from the direct surgery to the endovascular surgery. It's even Japan, we started the endovascular surgery with coil, but the much more clipping still we have done. But gradually increase. So recent couple of years, even in Japan, the percentage of treatment is almost 50-50, or a little bit more than the endovascular recently. So far, a lot of coils, there are many coils, 3D coils and the long coil, big coil and small coil, and the many companies make. And, there are a lot of various coils, and, we can use any coils. And this is a technique of to put a coil inside the aneurysm. So just one microcatheter, put a coil. It's a simple technique. And if the, neck is wide, we, protect the protrusion coils using a balloon. It means balloon assist. And using stent is a stent assist. Then sometimes we put a 2 microcatheter, is a double catheter technique. And so the coil embolization means the coil packing into the aneurysm sac as tight as possible. So let's say it is an old concept. So this is, our, the representative cases, the ICPC aneurysm. So put the 1 microcatheter is a balloon assist technique, put the coil, and the inflated balloon. It's a kind of a honey technique, So after that, we can put the coil as tight as possible like this. It's easy. even, this kind of vacuum aneurysm, we can make an two balloon assist technique. We put two balloons like this. So if so, we can make a tight packing very easily like this. And this is relative wide neck internal carotid acidorsal aneurysm. We put two microcatheters. One is for stent, one is balloon, and and also one more inside the aneurysm to put a coil. Put a coil, and after that, put a stent. It's a kind of stent assist technique like this. And this kind of large aneurysm, bachelor aneurysm, it's very difficult to operate. But to put the two microcatheter and the two balloon catheter like this, so we can make tight packing as tight as possible like this. It's easy. So coil embolization of several aneurysms is less invasive and effective, and very much effective for the small neck and small size aneurysms. However, wide neck or large size aneurysm are sometimes not perfect. So it means sometimes because of recanalization and regrowth. So that we have to think about that. It's a kind of new concept. And vascular treatment of several aneurysm using new device, something like flow diverter and also intrasaccular flow disruptor. It is not necessary put coils into aneurysm suck tightly. So this is the movie using the pipeline. It's a kind of flow diverter. So just a microcatheter, distally to the aneurysm, and insert and deploy is the pipeline. The flow diverter. It's like this. That's it. After that, gradually the aneurysm itself is thrombosed, and finally aneurysm shrink like this. So just because flow diversion or flow modification by stent mesh cause thrombosis of the aneurysm, and neointimal repair the defected parent artery wall by the stent mesh as a framework. So there are so many, the flow diverters already by pipeline, P64, FIL, FRED, surplus. And also flow intersaccular flow disruption wave, and also some contour or something. Anyway. So, but in Japan, we only can use the three types of flow diverter: pipeline, FRED, and surplus. As for intrasaccular flow disruptor, only wave we can use it. So far, I have performed the pipeline more than 300, including proctorship cases. And also FRED 47, surplus 13, and also the wave 15. So this is a pipeline. So everybody knows it's the most popular flow diverters, also in Japan, like this. And this is FRED. It's a dual layer. It's a little bit different type of flow diverter, but we can use this flow diverter more widely. And this is surplus. This is the third flow diverter in Japan we can use, but still it's a little bit problem. It's a kind of the gradually widespread. Anyway, so I already show you my case. So, but so this is. The pink dot is balloon assist. Balloon assist means, it's a coil embolization, right? And stent assist means, indicate the yellow line. So orange line indicate flow diverter. Flow diverter we can use from 2015. The first we use the pipeline, the gradually increase, and the last year I participate the case of a pipeline. Flow diverter is more than 100 case. It means the coil embolization decrease. Instead of coil embolization, flow diverter increase. So this is my home hospital, the Tokyo Medical University Saitama Medical Center. This is a result of flow diverter 2 years ago, up to 2 years ago. We have performed 132 flow diverters so far. So we analyzed the pipeline 104, Fred 24, surplus 4, and indication is the more than bigger than 5 millimeters. But the initial couple of years only more than 10 millimeters, big size. And this is 132 cases resolved. Technical success is 100%. Every case we can deploy the pipeline and flow diverter. Usually one flow diverter, but a couple of cases, more than 2, 3, 4, 5. And with coil, the 30%. And after deploy the flow diverter, we perform the PTA almost 3/4. I mean the 75% of cases. So this is a complication. Still we have some complication, but the complication rate is little, and I think this is acceptable. 3% morbidity and 2.3% mortality. So especially for this mortality, it's a very big aneurysm. So something like a 25 millimeter, 30 millimeter aneurysms. So this is follow-up result. The imaging follow-up is a 1 year follow-up. After that, the more than 80% is acceptable. 2 years, 98% is occurred. And the 3 years, almost 100%. And how about clinical follow-up? So after 1 year, retreatment rate, it's a little bit, the 6%. But more than 2 years, it's 0. And after 2 years, no clinical deterioration like this. So this paper, everyone knows the PAFS trial. So, after the flow diverter treatment, even the 3 years, the complete occlusion is 93%, but after 5 years, it's increasing. Even the little bit remnant, the couple of years later occurred. So it's very, very effective. So let me show some cases. This is pipeline, the big aneurysm with coil, internal carotid artery aneurysm. So with coil. So 1 year later, it's a completely occlusion like this. And this is also the pipeline, the paracrinoid 12 millimeter, 6 millimeter, 12 millimeter with coil also. So 1 year, it's clear. So this is the Fred case. So also like this, cure. So this is a very wide neck. Maybe we need stenosis coil, but just the pipeline, it's very, very good result. So this is also Fred like this. And also, this is a very nice case. It's a kind of tandem region. For this particular case, the coil embolization is very, very difficult. But, just put one flow diverter, that's it. It's very, very easy. This is also, this kind of aneurysm, for the coil, it's a little bit risky and also difficult. But flow diverter, you just put one flow diverter, deploy maybe 30 minutes. It's very easy. But some cases, still, the very difficult case we have. But this kind of case, for the flow diverter case, maybe a couple percent. It's very, very rare, but still, But even the coil embolization, in some cases, of course, very, very difficult. Just the same. Let me show this case, 13 years boy, the bilateral ACNS. Especially left side is this kind of ugly looking very big aneurysm. The one IC petrous 4 centimeter, and the distal the cavernous and 2.5 millimeter, 2.5 centimeter, like this. So finally, we put 9 flow diverters pipelines connected. So, we can make it, but, it takes about 7 hours. Reason why, during the procedure, between the 5 and the 6 flow diverters, once disconnected. And, after recovery shot, we can make it, but, it was very, very difficult. We don't have enough time to just show the image like this. And the first we navigate the microcatheter up to distally and to the distal MCA like this. And the first pipeline like this. And then second, third, 4, 5, and 6, 7, 8. Not easy, but finally something happened. Disconnected like this. After that, anyway, we have to navigate the microcatheter again. It's just very, very difficult. But anyway, finally we made it. You can see the very complicated route like this. But finally, we connected the 9 pipeline like this, and finished. So this is the last angio, and this is the follow-up MR, the 1 day and the 2 months. And patient was become, the asymptomatic and, become great. And this is, follow-up angio, 5 months after treatment, like this. Still a little remnant in the proximal, petrous portion, but, aneurysm shrink and, the patient symptoms completely recovered. So this is a 3D. I'm sorry. Yeah, like this. This part a little bit remnant, but almost cured. Like this. So also right side we put the 4 pipelines out. I'm sorry. So this kind of flow diverter is the very, very effective and good treatment, I think. So then I have to move the wave intrasaccular flow disruptor like this. So this is also the cartoon made by Thermo Microvention company. So this is the mesh mesh back and very thin metal woven. So just like a box. And, put a microcatheter inside the aneurysm and deploy like this. And then detach. That's it. For this kind of bifurcation aneurysm, so this is very nice. After deploy, the gradually thrombose, and especially in the surface of the neck, the fibrous, the tissue covered completely. And deployed like this, and so this is my case. This is the middle cerebral aneurysm. Of course, this is very easy for clipping, but for the coiling, sometimes it's very difficult, and also the easy to recanalize. So something like to put the stent like this, but put the wave, it is very easy because the microcatheter just push. It's spontaneously the getting the aneurysm sac very easily like this, and deploy. So you can see like this. So this is just after the wave like this. And yeah, this is the result. So this is the before, and this is the just after. And this is 1 year after the treatment, like this. This is 3D. So very nice result. So this is my conclusion of the new concept. Conventional intrasaccular coil embolization with some adjunctive technique is still useful for many aneurysms. And even for difficult aneurysm, for conventional intrasaccular coil embolization, the new approach using flow diverter or intrasaccular flow disruptor are very effective and better method. Endovascular treatment of cerebral aneurysm is still in progress, and it is one of the first choice treatment for the cerebral aneurysm, I think. So this is the additional topic. What is expected during direct surgery right now in present? I think it's, the case for ruptured aneurysm with massive hematoma, it's better than the endovascular, and the direct surgery is better. And the case easy for direct surgery and difficult for endovascular treatment. So this is maybe direct surgery is better. And also, I believe with some bypass surgery, combined with bypass surgery, is sometimes it's very, very effective because so we can sacrifice the, even the important branch if the, bypass surgery is completed. So let me show the case. So first, ruptured aneurysm with massive hematoma, like this. This is a case, 72 years old male, subarachnoid hemorrhage, and subdural hemorrhage, due to ruptured right MCA aneurysm. So this is, the patient was grade 5, near grade 5, and also the, anisochloria also appeared, like this image. The right MCA ruptured, so the massive subacute hemorrhage with subdural hematoma like this. So, definitely it is necessary to decompression like that. So this is also also neurological pulmonary edema. Its condition was very bad. So 3D CT angio showed the right MCA aneurysm like this. So, the looks like even the shape is, better for the direct clipping. But anyway, so we did like that. So, the massive subdural hematoma like this, and after removal, and also the exposure, the aneurysm, and, the multiple clipping like this. The clipping is not so difficult. So this is after surgery. And, the clip is like this. And the patient gradually recover, but not completely anyway. So next case is MCA, also MCA ruptured, the 88 years old female, the grade 4, the massive, subacute hemorrhage. The, intracerebral hematoma. So, it needs the decompression. But, the aneurysm figure, we can make an endovascular surgery. But, anyway, we need some decompression. So, the clipping. Also, clipping is very easy like this. So the other situation is easy for direct surgery and difficult for endovascular treatment. Like this. Also MCA aneurysm. Sorry. So this is left MCA and this is unruptured. Even unruptured, of course, we can treat even this kind of aneurysm, using a stent assist, or double balloon assist technique. But, durability is not so good. This is also we can put some web device, but, this is too shallow. So, even the web is not so very good case. But, clipping, it's very, very easy. Like this, after clipping, easy. Okay, the last situation is IVR with bypass surgery. So let me show. It's, the right IC and true PCOM aneurysm. True PCOM means, the internal carotid artery big aneurysm, and, also from the dome is a PCOM PCA is, the supply. And especially for this case, is a P1 is almost hypoplastic, no P1. We don't, we can't sacrifice the PCA. So for this kind of patient, if we can, make an STA PCA anastomosis, it becomes very, very easy. After that, we put a stent. No. It's a flow diverter and coil as much as possible. That's it. It's very easy. So, but, STPCA is sometimes difficult. So we need, the very talented technical neurosurgeon, but bypass surgeon. But, in my team, it's we have a very good, bypass surgeon. So I asked him, after the bypass, like this, so it's effective. If so, it's easy. After that, just put the flow diverter and coil. That's it. So this is, the movie during the endovascular surgery. So first, we confirm the bypass is effective, like this. And then the guiding catheter, inner carotid artery, and this is, the usual pipeline. and a coil. That's it. It's for this case, with the two pipelines, overlapped like this, and then the PTA and the put coil occurred like this. After the procedure, the patient was good. So this is final. And also one more case, this is a big MCA aneurysm. 18 millimeter, this kind of aneurysm. This type is a little bit difficult even for creeping. And, the endovascular also difficult because, this branch, we don't have to, if it can be sacrificed, it a little bit easier because we put some flow diverter from M2 to M1 and put a coil. It's a very good treatment and safe. But just put the flow diverter and coil, maybe this branch is crude and some infection occurred. So first, also we asked the American bypass, it's MCA, so it is not so difficult. And after that, we put the stent and the coil like this. So this is a movie during the procedure. After this branch already bypassed. And this is wide neck. So sometimes it's very difficult to, the cannulate to the distal MCA. So this is also looks at. So first, the intro, dome, but for maybe big microcatheter, it's very, very dangerous. But for this type, it's only 10 microcatheter, 080, 010. So once we navigate the small microcatheter like this, then this is second one. It's a kind of sheep technique. If the one is inside, already inside, the second one is a little bit easier. So this is the big microcatheter to deploy the thread. And then put the thread like this. And coil as tight as possible like this. That's it. And after result, the patient was good. So this is not followed more than 1 year. So still, we just follow up. But, we believe the aneurysm will be cured. So like this. So this three situation is even right now what is expected during dark surgery, I think. So, I talk the endovascular treatment of the cerebral aneurysm right now, the new concept, especially of the flow diverter or wave. Thank you very much for your attention.
Thank you, Professor Hyodo. Can you hear me?
Yes.
Okay. Okay, thank you very much for your nice presentation. So, as he stated at the beginning, he has done a tremendously large number of operations of both endovascular and craniotomy. And as you know, he's one of the greatest pioneer in Japan to start as a hybrid neurosurgeon who do endovascular and craniotomy. And today he presented a large number of standard endovascular technique and as well as highly sophisticated, very, very complicated treatment. And so, Professor Hyodo,
Yes.
I have some questions. Is it
Okay.
okay?
Yeah,
Okay.
sure.
First one, you did a 30% of patients, you did pipeline and coiling, right?
Yes.
So I would like to know what is your criteria to put coils in the case treated with the pipeline?
Okay. To use a coil is two purpose. One is to protect the delayed rupture.
Okay.
So for that case, is typically the bigger aneurysm, more than 15 millimeter or 20 millimeter like that.
15 to 20.
50.
Okay.
15, more than 15. So we put some coils. And also the if the aneurysm is intracranially, intercranial located aneurysm, the more than 10 millimeter, and even the small neck aneurysm, just like jet flow or something like that.
I see.
Yeah. But if recently we can treat even the more than 5 millimeter and 10 millimeter, between 5 to 10. So if so, the just 7 millimeter intercranial aneurysm, we don't put any coils.
Okay, you mean aneurysm more of intradural or subarachnoid space is more dangerous to rupture by putting some pipeline.
Yes.
Okay, and you have 3 cases of delayed rupture after pipeline.
Yeah, right.
What are those patients? Did you put coils?
Yeah, that is our initial cases. Almost.
I see.
We didn't any coil, but the one case is a very, very big aneurysm. Even the put a coil, that ruptured. So it's very difficult to say. That if we put a coil, it doesn't mean completely okay, but the risk might be reduced. I think. I believe. Yeah.
Okay, thank you very much. There is one question from the audience. Is there any selection criteria of types of aneurysm based on anatomical location, the size of the neck, presence or absence of daughter aneurysm, benign, being ruptured or unruptured, to use the flow diverter technique? Selection criteria.
Selection criteria is which is flow diverter or which is just coil. So it means
I think so.
Okay.
Anatomical location and size, daughter aneurysm, rupture or non-rupture.
If the put a coil, it's very easy. Something like small neck aneurysm. So we just put a coil. So no flow diverter.
Okay.
Yeah, but if the wide neck, and also if we put a coil, sometimes it's necessary to use some stent-assisted coil embolization. So for that case, from the beginning we put a flow diverter instead of just stent.
Okay.
So yeah.
So how about the subarachnoid rupture case, subarachnoid hemorrhage?
Ruptured case. In Japan, it is not allowed to the acute phase for using the flow diverter.
Right.
So sometimes, the put coil, just balance this coil if possible, and just keep 1 month. After that we put the flow diverter.
Okay, you can put pipeline after 1 month.
Or more than 2 weeks.
Coiling. Okay.
Anyway, yeah,
You
but
mean,
2 weeks is just 1
Okay.
month procedure. So just insurance reimbursement.
Mhm.
So the next month is better.
Okay. You
Yeah.
mean it's a chronic stage, right?
Yeah, exactly.
Okay. Okay. So is there any question from the from Ben? Do you have some question?
Yes. So my question is about the choice of the different flow diverters. I want to ask because there are many brands of the flow diverters. So, for example, you have a pipeline, and there are some newer devices like the Ripple and Surpass. So, is there any difference in terms of opinion that which one is better, or which another problem is about the anti-platelet regime with different types of the flow diverters? I think in your experience, what is your opinion towards the different brands of flow diverter and their respective anti-platelet regime?
Okay. First, which flow diverter is the best for me? It's you already understand. And my case is the full pipeline, the more than 300, and the FRED just 47. It means the result. Actually, I trust the pipeline very much. But for some particular case, especially for the vascular, or the some mesocerebral, anterocerebral aneurysm, this is not allowed to use the pipeline. It's a Japanese condition. So for that particular case, we have to use a FRED. It's a different pipeline, flow diverter. And also the Surpass is the third, the flow diverter in Japan. It's a kind of different purpose. We have to become a very good friend for every company. Because the every company have every different devices, and especially for Surpass. Now we can use the Surpass is just the first generation, but in the world already they're used in the second or third generation. So now if we use the Surpass, even the first generation, then they introduce the second, third generation, then we can use the as first as possible. So we have to become a very good friend. But anyway, pipeline is I think is the so far the best flow diverter in Japan. And for the anti-platelet therapy, each flow diverter, I think it's the same, But recently, it's a kind of the coating and shield technology introduced. If so, maybe this kind of flow diverter, maybe we can reduce the anti-platelet therapy.
Anti-platelet agent.
Yeah.
Yes. Do you monitor ARU and PRU in your cases? For
yes,
those
every case we monitor. Just before, the 1 day before treatment, if this is not effective, we have to change. For example, from clopidogrel to prasugrel or something like that. Yeah.
Thank you so much.
Yes.
So I saw Joey Sam also raise his hands.
Hi, thank you, Ben. Hi, Prof. Kato. And Prof. Naoya, thank you for chairing the session. And Prof. Hyodo, that was a very informative session as usual. I think you will be the best person to answer this question. As you know, in certain parts of the world, cerebrovascular surgeons are one group, and the other group is controlled by maybe interventional radiologists or endovascular treatment. So, in your opinion, as a hybrid neurosurgeon, let's say if you have an aneurysm unruptured, which can be treated by both, equally safe, equally effective. For example, ICA PCOM aneurysm. How do you actually counsel your patients, or do you decide for them beforehand? Do you let them decide, or how do you go about this, since you can do both? And on top of that, is there any medical legal law problems in where if a lesion can be treated by both and you don't offer one, and the patient can say, why didn't you offer me clipping, or why didn't you offer me endovascular treatment and you preferred this? Thank you.
It's a very difficult theme. It depends on the each doctors. Even the 10 hybrid neurosurgeon there. The maybe first 3 is much more the endovascular, and the last 3 is much more direct surgery. It depends.
Yes.
But recently definitely move to the direct surgery to endovascular in Japan. Or this is not only Japan. Maybe all over the world, I think. Yeah, just because of I already said the endovascular treatment is still in progress. Of course, the direct surgery, even direct surgery, there's some the special technique. Something like monitoring or some, but much more in the endovascular.
So I guess there's no right or wrong in something which can be done both ways. There's no right or wrong if it can be done safely both ways.
Yes, in both ways, we can done safely. But of course, the endovascular is better, right? I don't think that everybody can be opened the scar.
Okay, Professor Hyodo.
Yes.
We have some guest discussant today. So any discussion from guest discussant?
Hello.
Okay.
Hello, can you hear me?
Yes.
Hello, can you hear me, Dr.
Hi, how are you? Yes, we can hear.
How
are you?
I'm fine. Okay. I don't know how to put the video on. It's not getting. Anyway, see, the thing is, there is one comment. A patient with a grade 4-5 subarachnoid hemorrhage who had only acute subdural hematoma. Why can't we have both the things? You could have gone ahead and removed the acute subdural, and then you could have coiled the aneurysm. That would have been less morbid rather than removing a subdural and then clipping the aneurysm in a patient who is already grade 4 or 5 and the patient is elderly. What are your comments on that? Dr. Hyodo, please.
Yes. So direct surgery means anyway we need the decompression.
Okay.
So if the subdural hematoma, so if we remove subdural hematoma, it's a big space, and also especially for the middle cerebral artery aneurysm, it's very easier to make a clipping. So and also just after open and then clip, it's we can make it within a very short period. And if we change to the endovascular, we have to do some it's a kind of antiplatelet treatment, or some
no, if you are just coiling the aneurysm, there is no need to give antiplatelets.
Really?
If you are just coiling the aneurysm.
Antiplatelet we don't need, but heparinization we need, right?
Yes,
Yeah.
that probably, yes, that is correct. But there are many grade 4 or 5 patients
Mhm.
in whom there is a surface hematoma
Yeah.
and the patient is in a bad shape. It is
Mhm.
better to do both the procedures because the other procedure is comparatively less morbid because there the dissection etc. is not required.
Yes.
Unless and until the other patient had an intrasylvian hematoma,
Yeah.
there
So
definitely you
yeah,
need
I
to remove
agree,
the hematoma,
with
then
you.
you operate.
Yeah, but it depends, which is yeah, even the subdural hematoma, yeah, we take it out, and also in the vascular, it's a one of
Yeah.
option. But compare with each situation, so we have to decide which is better.
Is there any endovascular thing coming up nowadays
Mm-hmm.
in which the antiplatelets may not be required? Is there any work going on that?
But in my clinical situation in Japan, so maybe now using endovascular technique, at the beginning usually give them the antiplatelet routine.
Are there any new devices coming up where the antiplatelet may not be required and we'll be able to put the endovascular device right at the
Some
time
shield
of
technique or wherever we don't need. I know.
in what?
Web.
Web. Okay.
Web.
That is correct. That intrasecular devices were like WAG, or there may be a contour device also recently.
Yeah,
If you
right.
put those, then the intrasecular devices, the antiplatelets are not required. But is there any intravascular device also? Some work is going on in which probably the antiplatelets will not be required. Any future? That's what I'm asking.
Yeah. In future, it's changing. I thought it's at the present condition.
Oh, no, I agree with you.
No,
It
we
was
have
an
no
excellent
idea. We have
presentation.
no idea about that.
Hmm?
Okay, so Professor Bosniak,
Yes,
are you here?
hello, I'm here. Can you
Do
hear me?
you have any comment?
Yes.
Okay. Thank you very much. Thank you, Professor Kawayama, Professor Hyodo. Thank you very much for
Yes,
excellent presentation. Really very good cases, excellent technique. Thank you, really great. As a discussant, as a commenter, so let me maybe dig to the history a little bit deeper and look at the problem a little bit wider. So first of all, I like to remind, when I started my practice, I remember that we started with the balloon occlusion of the aneurysm. I think you also did it, but no, we almost forget about it. But you remember that custom-made silicone balloons which were prepared. The school from Serbinenko, and I was happy to work together with Professor Shcheglov in Kiev. He launched a very well-known school, which his son is working now. This clinic is really very good, one of the best in my country. And when I saw the web device, I suddenly thought that it's quite similar to the balloon. Idea is similar, so maybe the evolution is going on the spiral shape going ahead, because this device got something from balloon occlusion. Of course, it's different, but idea is very similar. This is one thing I'd like to speak about. And another thing, it's about a role of endovascular neurosurgery. Of course, more and more patients with aneurysm are treated successfully by endovascular technique. At this time, we have enough experienced conventional surgeon to do clipping, to do cranial surgery. But every year we have less and less prepared surgeons. There was a requirement, 50 cases per year for normal practice for vascular neurosurgeon. Now it's difficult to find the center where they have 50 cranial surgeries per year. If it for 15 years back, they have hundreds, but now majority of patients are treated endovascularly. So, and my message to young neurosurgeon to keep their skills on some level. They must go for training to cath lab. They must do this simulation surgery, and they must extend their activity to other cases like neuro-oncology cases and so on, to be always be ready, because it's really a problem. We have less and less neurosurgeon for good cranial surgery. So if you remember, we had so many superstar neurosurgeons 20 years ago, and now we have less and less of people like this. So this is my comment, but in my question, Professor Hyoda, I think you have your experience, you have your own option to the management of fusiform aneurysm, especially fusiform aneurysm of basilar artery. So there is no one decision. It's quite a discussion question, and may I have your comment towards this pathology, and maybe how do you see the progress in the future for the management of this pathology?
Okay, thank you very much. I completely agree with your opinion. And your question is about megadoric basilar aneurysm, like that.
Yes. Like
yeah, that kind of disease is very difficult to treat for any kind of treatment. But still, if possible, I want to put Flodivata. I have three cases. That just like that. So one case is a very big, the megadoric basilar. From P1 to the basilar artery, we put 5 thread devices connected. And one is a big aneurysm that 3 stent, and within 3 cases, one case in the just after treatment, the 1 day after treatment, the aneurysm rupture and patient died. But the one case, it become the great result. They become better and better. And the one is the just treatment period too late. So 6 months later, and they suffer from pneumonia and die. But anyway, so I think this kind of technique is the last choice to treat. But even though some of cases not so complete, but some of them it's work.
And maybe there is a sense to think about bypass surgery, maybe in these cases. Yeah. So okay, thank you very much. Thank you.
Thank you, Professor Bosniak. So is there any comments or questions? Okay, so thank you very much, Professor Hyodo, for your nice presentation. So very sophisticated presentation. Thank you very much.
Thank you.
So are we moving to the next presenter? Is it okay?
Yes, maybe Professor, you can introduce our YNS speaker as well.
Or you can introduce.
Okay, sure. So thank you so much, Professor. So the second YNS speaker is Dr. Ha Kiran, who is the attending consultant in the Paras Hospital in New Delhi in India. So today his topic will be an endoscopic evacuation of ICH, introduction to young neurosurgeons. So may I introduce? May I request Dr. Kiran to share his screen? Hello, Dr. Kiran. Can you? Yes.
Hello.
Hello. Yes, I can hear you now.
Can you see my screen?
We can see your background in the laptop.
Okay, yeah. Now?
Yes.
Yes,
Yeah.
yes.
Yeah. Thank you. Good evening, teachers. I am Dr. Harikiran, a young neurosurgeon from India. Currently, I am the fellow in Fujita University under Kato Sensei. So very happy to be here and in this platform under your guidance. So since neurosurgery is moving towards a minimally invasive concept, I think endoscopy is going to play a key role in the coming future years. So, and I think all young neurosurgeons should adapt to endoscopy. So today I will present some basic introduction to endoscopic evacuation of ICH. So the main aim of our treatment is to reduce the size of the clot and prevent its secondary effects like edema. So the size of the clot can be reduced either by surgery or by correcting the coagulation deficiencies. And here I want to emphasize that if you can reduce the blood pressure in a controlled manner, you can prevent many secondary hematoma formations. So in 2021 guidelines of Japanese Stroke Society, they have stated to keep the blood pressure under 140 millimeters of Hg in systolic and 110 mm of Hg in diastolic for at least for 7 days to control the rebleeding. And the rapid reduction acutely may cause acute kidney injury, so it is generally not advised. So these are 2021 Japanese guidelines for ICH evacuation, and they have recommended grade C to endoscopic evacuation, which implies that the procedure can be considered. So at this stage, we are in grade C, which means the procedure can be considered. So in case of pituitary bleed, if the size of hematoma is more than 30 ml, or if it is causing mass effect, then it is considered an indication for surgery. In thalamic hematomas, currently there is no indication for acute settings as of now. And in cerebellar hematomas, if the size is more than 3 centimeters, or if it is causing obstructive hydrocephalus, then it is an indication for surgery. In lobar hemorrhages, it is mainly based on individual cases. It can be tailored according to the cases, and there is no specific recommendation for lobar hemorrhages. As per the timing of surgery, for timing of surgery for endoscopy, there is no specific or common agreement. One study here, which I have mentioned, showed that in case of ultra early surgery, that is within 4 hours from the onset of the bleed, so the risk of rebleeding, there is an increased risk of rebleeding. But now there are many different trials going on with the newer techniques. So maybe in future we can get a good results in ultra early surgery of ICH. So another study here, it states that if the endoscopic surgery is performed within 6 to 12 hours, so after 6 hours, so it is better in the outcomes. So ideally in patients with GCS score of 9 and hematoma quantity between 25 to 40 ml may benefit better with the endoscopic procedures. So these are some of the patterns on CT scan which can predict the risk of rebleeding and hematoma expansion. So I wanted to emphasize on these patterns. So next time when you see the CT, we can look for these signs. So first one is spot sign. Spot sign is seen in contrast CT. So it is a small tiny enhancing foci within the hematoma. So this implies that contrast is coming out. So, and also it implies that it is actively bleeding. So hence it can predict hematoma expansion. And the other two satellite signs and island signs both are shape markers which are seen on plain CTs. So these are small hemorrhages which are seen away from the main hematoma. And in comparison to these two signs, overall island sign shows a better prediction of hematoma expansion than satellite sign. These three are swirl sign, black hole sign, and blend sign. These three are density markers. These three are also seen on plain CT scan. So swirl sign and black hole sign are basically low density area within a hematoma. And black hole sign has a high specificity for predicting hematoma expansion, and patients may have worse outcomes if there is this sign present. And blend sign is a hypodense region which is adjacent to the hematoma, and it is also specific for early hematoma growth. So a combination of a blend sign and island sign can accurately predict hematoma expansion in 92% of cases, according to one study. So here two images are shown, which is both the blend sign and island sign. If both of these are present, then we can think that there can be a rebleeding. So overall, among all these signs, the spot sign is the best reliable indicator. If the sign is present, there is almost a good amount of sure that a patient will have a rebleeding. So this table shows the advantage of endoscopy over microscopic evacuation. As you can see in this table, that in endoscopy, there is better visualization and better control of bleeding. And most importantly, the damage to the overlying brain is very minimal in endoscopy, which is a major drawback in microscopic evacuation, since we have to retract and see the hematoma in the corners. And a meta-analysis was done between endoscopy and microscopic evacuations by Zhou et al. And they have concluded that endoscopy has better reductions in complications and improved outcomes. And they have published a paper on results in this paper. Here I want to show you some instruments which are used in endoscopic surgery. There are many types of transparent sheets you can use. You can either use cut syringes with gloves, or you can use EVD catheters with a glove inflation, or there are pre-made transparent sheets. We currently use a Neuropore, which is shown in the down image, which is 10 mm and 8 mm in diameters for both ICH and IVH evacuations. On the right side, this is a suction tube, which is also a special design, which has both irrigation, suction, and monopolar, all three integrated into it. And only the tip of the suction tube cauterizes, and the rest of the black part is insulated. And it is always advised to check your scope sizes and endoport sizes before you start the case. So the endoscopic procedure is basically divided into 4 steps. One is, first is you have to identify the burr hole point, and then you start creating the puncture by using transparent sheath, and be sure of the trajectory, and always calculate the trajectory before the surgery. And the third one is suction of the hematoma, and always under guidance of the endoscope, do not do blind suction. And the fourth point is hemostasis. So for hemostasis, you can use the already integrated monopolar in the suction cannula. So these are some of the strategies which are useful during surgery I wanted to share. So the location of burr hole is very important, as it may impact a lot on surgery. So always it should be located so that it will not damage any vital structures in the path, and it should be located along the long axis of the blade. In this adjacent picture, we can see the importance of placing the burr hole along the long axis. An ellipsoid bleed, which is most commonly common, is the best approach to the frontal long axis rather than temporal. If you approach to temporal, you may not evacuate the full bleed. So that is the inference. And the size of the burr hole is also very important. Always make the burr hole size between 1.5 to 2 centimeters, so that you can change the direction of the sheath and you can see inside the hematoma cavity. So the burr hole size is also very important. Usually for subdural hematomas or intraventricular hematomas, we put burr holes at Coker's point. And for cerebellar hematomas, it is at the midpoint between mastoid process and inion. And for lobar hemorrhages, it has to be tailored according to the case. So for during sheath insertion, always look for the surface blood vessels. Identify the blood vessels, and you have to insert where there is no blood vessels. And always before the surgery, measure your distance, trajectory, and angle before the procedure. And sheath, when you are inserting the sheath, it has to be guided to the boundary of the hematoma and the parenchyma. And the endoscopes, in endoscope, 0 degree is most commonly used. And during hematoma aspiration, always go from the shallow to deeper regions. And you do hemostasis regularly. In the right picture, it is depicted that brightness in the endoscope changes. When you gradually advance the scope, it is always better, and scope is always brighter. So rather than directly going into the hematoma, which you will encounter a dark scope. So these are some of the cases which I wanted to show you. For case number 1 is a 65 years old male with right parietal occipital ICH. This is the pre-operative scan. And patient was taken in for operation theater. Patient incision, small linear incision was made. Burrow size of around 1.5 centimeters made. This is the transparent sheath which we have introduced. And now the hematoma evacuation is started, and you can see hematoma is being evacuated. And this is the post evacuation of cavity. You can irrigate it and look for any bleeders. And if you don't find any bleeders, you can put hemostatic agents like we use a Sergi wool, and dura is closed like this, and very small incision around 1 centimeter. So this is the case number 2 of patient having left terminal hemorrhage. So in this case, we approach it through the frontal burrow. This is the intraoperative video. Now we are in the hematoma cavity. Aspiration of the hematoma is going on. In this video, I wanted to show you the change in the direction of the angle of the sheath. You can see here that we are changing the angle of the sheath and evacuating the remaining hematoma also. So this is the advantage of putting a little bigger burrow. And after irrigation, look for any bleeder point. In this case, we were able to find a bleeding point. You can see the bleeding point is getting cauterized here by the tip of the suction. This is the bleeding point. So after this, cavity is being inspected, and we cannot see any more hematoma. Now the sheath is gradually being retracted, removed out. So you can see there is no brain retraction in the surrounding part, and the corticectomy size is also very small. This is the post-operative image of the same patient. You can see almost hematoma is almost removed completely. This is the case number 3 with 53 years male with paternal and both ICH and IVH. So in this case, I wanted to show you that through a single burr you can evacuate both ICH and IVH, and it is also very minimally invasive. And first, initially, you can put the scope in and evacuate the ICH, and then change the direction, go into the ventricle, and you can even evacuate the whole complete intraventricular hemorrhage also. So this is the operative video. Here we are evacuating first the ICH through the same burrow. And we have changed the direction and gone inside the ventricle. This is we are in the ventricle, and the whole ventricle is filled up with bleed. So during the evacuation of bleed from intraventricular, you can just put your scope near the bleed and you can aspirate it. So that's how hematoma is aspirated. And this is the post aspiration image. You can see almost the ventricle is free of hematoma. Here we can see there is with the use of flexible endoscope, it is a good advantage that we can go up to 4th ventricle and clearly see all the ventricles. So this is the advantage in using the flexible endoscope. As you can see in all the ventricles, hematoma is almost clear. So this is the post-op imaging showing almost complete removal of the ICH and both IVH. So this is a case number 4, patient having left cerebellar bleed with IVH. In this case, we placed the burrow in between inion and mastoid process, and then we were able to evacuate the hematoma, and then we entered inside the 4th ventricle, and then we evacuated the hematoma from both 4th and 3rd ventricle also. So this is the operative video of the case. So here cerebellar hematoma primarily firstly is being evacuated. And after that, we entered into the fourth ventricle through the hematoma, and this is some clot in the aqueduct, and this has been removed. Now there is a free flow, no hematoma in the ventricles. So this is the post-op image of the same patient. Cerebellar hematoma is completely removed, and there is no IVH also. And here there are some basic complications which you can encounter during your surgery, during your beginning stages. So these complications have to be kept in the mind. So damage to the adjacent brain or perforating vessels can be avoided by adjusting the suction pressure. So you modulate the suction pressure, and there is an instrument, this instrument you can use to adjust your suction. And this instrument also can be very helpful in beginning stages of your career. And if the operative field is unclear due to continuous bleeding, always do hemostasis at every point, and always confirm that you are in the normal estimated trajectory, and always confirm the normal brain in the transparent sheath. So generally there are two types of clots, hard clot and soft clot. Mostly there is a bleeding point underneath the hard clot. So when you encounter a hard clot and it is a little difficult to remove, so it is always advised to leave some amount of the hematoma. So there is no rule that you have to remove the 100% of hematoma. If you are having little trouble, you can leave some hematoma also. And to avoid post-operative bleeding, you always layer with either hemostatic agents. Generally, we layer with Sergi wool. You can even put flow seal also, and don't be too aggressive. And generally, in the beginning stages, we tend to be very aggressive and try to remove full hematoma. So that is not advised. Many senior surgeons I have seen, they leave a thin layer of clot attached to the brain, which is where the most commonly bleeding point is present. So always don't be too aggressive. And fifth point is suspected vascular anomaly. Always you should have clinical high suspicion if there is age of patient is very less or the profile is not fitting and you suspect any vascular anomalies. Always evaluate before the surgery, and because it can be catastrophic if you open these cases. So these are the future trends in endoscopic surgery. The left one is, these three are mainly currently under trials. The left one is the Integra Surgiscope, which consists of a disposable sheath and a reusable camera. And there is a separate attachment for ultrasonic aspirator. So combining all these three, you can go in through the endoscope, see the clot, and through the ultrasonic aspirator, you can just suction the clot easily under visualize. And these are also very thin, and this sheath is also single time use. So this is a newer technology. And the right one is Artemis evacuator. This is a basically suction and irrigation device with a wand. The wand contains vibrating tip which can break the clot. So, and the main advantage of this system is it is very thin, so it can be put inside the 6 mm sheath, and you can put your suction. You can put your endoscope inside it, and you can marsupialize the clot, and you can remove the clot. And below one is a brain path by Nico. These are tubular retractors with reusable obturators. So the main advantage is you can use navigation system through it inside the obturator, and you can precisely know where your transparent sheath is going. And these are some of the trials going on in endoscopy. Currently, all the trials are going on, and only 2 trials have been completed, and the results are yet to be published. So the first 3 trials are used in Artemis systems, and the second mirror and evacuate trial is being used in a Surgiscope. So mainly the results of INVEST trial and DIST pilot trial we are eagerly awaiting, because in DIST pilot study they have included very less amount of hematoma also. They have included all the patients who have more than 10 ml of hematoma. So it is going to be interesting to see the results of these trials, which are I think which will come within less than 1 year. So to summarize the topic, always use minimally invasive surgery whenever possible. Endoscopy is a good option to consider for ICH or IVH removals. Pre-plan the whole procedure and always visualize each step before going into the procedure. So always have a plan before going into the surgery, and learn from the masters, because it is still the beginning of our careers. So we need to go and train from the masters in the respective fields, and spend some time for research. Yeah, thank you.
Okay, thank you very much, Dr. Harikiran. Can you hear me?
Yes,
Yes, we
yes.
can hear you. I
All
understand.
right, thank you. So he presented about the very detailed technique of endoscopic aspiration or evacuation of the intracerebral hematomas. And I would like to invite two discussants who are Professor Ahmad Pirza and Professor Bosniak. Please.
Okay. Who is the first? Professor?
Yes, yes, go on, please. Thank you.
Okay.
Professor
Okay.
Alexander, you can.
Professor Ahmad?
Yes, yes.
Can you speak first?
Hello, greetings. Salam alaikum.
Good evening.
Konnichiwa. Thank you very much. Very nice presentation, and also good and excellent achievement. Congratulations. This was
Thank you.
good, Professor Han Kiran. It was good achievement, and the science, especially neurosurgery, going to mini invasive and less invasive techniques, and it's good achievement, especially for countries with limited resources. It is good, and we hope and wishes someday we send our young neurosurgeon for training and learn from you and make skills and bring back skills to Afghanistan as well. Thank you very much. It was a nice presentation, and also I would like to say thank you for Professor Hoyodo for excellent presentation as well. Just I like to say thank you very much. Thank you.
Thank you, Professor.
Thank you, Professor Ahmad. So how about Professor Bosniak?
Yes, I'm here. Thank you. Dr. Kiran, my congratulations. You delivered the excellent presentation. Thank you very much. Very, very, very comprehensive, very logical, very illustrative, and a bit critical also inside. So thank you very much. I really enjoyed it. It's a really good job. I have some comments concerning the using of endoscopy for management of hemorrhagic stroke. Unfortunately, you know, the recent trials didn't reveal that any benefits of less invasive procedures for management of this treatment. But I hope that in future, minimally invasive procedure will take their place, and it will be proven they are really better than conventional normal surgery, and the indications for this procedure will be broadened a little. We can, because you know now we can operate on only deteriorating patient with intracerebral hematoma, but you understand that much better to remove minimally invasive way this clot to prevent the cerebral edema, to prevent the hemolysis and this toxic influence on the brain tissue. So it's logic, but the trials and meta-analysis are very maybe very tough things to step over. Sometimes you are on the level of expert, you see that it's much better, but when you read the results of some trials and analysis, and it couldn't be proven. But I believe that really this method will take its place in management of hemorrhagic stroke. And what is your opinion? How do you think? Is there the sense to operate on more patients with intracranial hemorrhage than we do nowadays?
Yeah, thank
What
you.
is your
Thank
option?
you. Yeah, thank you, Professor. I believe it is better to operate the patient early rather than waiting for the patient to have cerebral edema, and then patient will get deteriorated. And after that, when you operate, I think so that possible outcomes will be much better when you operate the hematoma early. So if you see the hematoma of a moderate size, at least more than 20 to 25 ml, so I feel you should go and operate, and by operating, I mean the minimally invasive surgery, not doing microscopic evacuation. This minimally invasive technique, which are newer techniques, are also coming, which are very minimally invasive, that is almost 6 mm. So you can go in early and remove the hematoma, and we can avoid further deterioration of the patients. So I think that makes little logical explanation. But still, as you have said correctly, the trials are not showing according to what we expect. But in future, maybe some trials are going on regarding this ultra early evacuation also. So I think that is going to be good, promising trend in the future.
Okay, thank you. I agree with you. I completely agree with you that the early surgery maybe will let us prevent the undesirable consequences of this of the hemorrhages, especially by using the minimally invasive techniques. So thank you. Thank you.
Thank you.
Okay, thank you very much. Is there any questions or comments from other doctors?
Pratik?
Yeah,
Okay.
thank you, Professor. Hori, thank you for your brilliant presentation. Basically, you have touched every point, and you have told so many benefits of endoscopic evacuation. And I also agree with you. There are so many benefits over microscopic through endoscopic evacuation, but few comments from you. Do you feel that in microscopic we can go through Transylvian approach to remove the putaminal or thalamoganglionic ICH? So is it less traumatic to brain because we are going to a natural corridor than endoscopic approach? Second question is, do you think that it is little bit difficult to hemostasis through endoscopic approach? And my third question is, sometimes some clot is very thick and it is difficult to evacuate through minimal endopole. And do you think that in that case, microscopic procedure is better? Or we have learned some techniques how to evacuate endoscopic approach by thick hematoma? Thank you.
Yes, yes. Thank you for your questions. Currently, there are they have done some cases through endoscopic evacuation of thalamic hematomas also. And mainly though they go through the parietal burr and then enter the ventricular cavity, and then they approach the thalamus. That's how they evacuate the thalamic hematomas. So there are only few studies. I don't have any experience in the thalamic hematoma removals. I have read about those, and they have said that endoscopic evacuation, although it is not from the natural corridor, but you can avoid a large, almost a medium craniotomy and exposure and all those things. It can be done through a small burrow and through a minimal incision. So that's my understanding of thalamic hematoma. And regarding the thick clots, most of the clots in IVH removal are some of them are thick clots. So basically we irrigate the cavity of the hematoma. So continuous irrigation may make the clot sometimes soft also, and then you aspirate and slowly you don't suck out the clot and you gradually lift it with a sucker and then roll the clot. So that is one advice to remove the hard clots. So instead of directly going to the clot and then sucking it out, first initially irrigate the clot, make it become softer, then you can roll the clot.
Yeah. And finally, regarding hemostasis, do you think that microscopic approach we can take better control than endoscopic?
That is the thinking, but in endoscopic surgeries, around maybe 90 to 95%, most of the times the hemostasis can be achieved through continuous irrigation. Maybe it can take some longer time. Maybe it can take some longer time and longer infusion of irrigation material. But ultimately, you can control the hemostasis most of the times. And if it is not, then you can always use some Surgiflow or hemostatic agents.
Yeah. Thank you. Thank you, Hori.
Thank you, Ravi.
Okay, thank you. Any questions?
Yes. Thank you. Thank you, Dr. Kiran, for your great presentation and really an eye-opening presentation concerning use of the endoscope. And I think the evidence for endoscopic cord evacuation is still pending for further investigation. For minimally invasive surgery for intracerebral hematoma. So I think the one of the evidence for it is the use of the hematoma drain that might have some evidence by the means trial. So for the endoscopic one, I think from my opinion of view, the intraventricular hemorrhage is different from intracerebral hemorrhage. For intraventricular hemorrhage, that you can achieve a cord evacuation quite safely. But for the intracerebral hemorrhage, that as mentioned by the other discussant, that hemostasis might be very difficult. So my question is that when you perform endoscopic evacuation of hematoma, would you also leave a hematoma drain in situ to I saw you mentioned that you try to achieve a partial the hemostasis. So would you leave a hematoma drain in situ so that if there is still persistent hematoma, then you could perform, for example, urokinase injection in the later few days when the hemostasis is secure?
Thank you, Ben. Most of the times, if we find that hematoma is very large and more than 50 cc or something like that, then we leave a small EVD drain inside the hematoma cavity to drain the remaining any hematoma if it forms a later stage. But around 50 to 60%, we don't leave any hematoma. We make sure to achieve hemostasis. We even irrigate the cavity after the evacuation also and make a final check also. And still, if you have any doubt, you can always leave a small EVD catheter inside the hematoma cavity. So that's how we do it.
I see. Thank you.
Thank you. Thank you.
All right, thank you. Can I have one question? Is it okay?
Yes.
So, how do you exclude the vascular malformation as a bleeding source of the ICH? Do you use always CT angiography to every patient?
No,
suspicious patient.
Yes, suspicious patient. Generally we go by the clinical criteria. We see if the patient, when we ask the history, we ask them about hypertension, whether he's on regular medication, did he skip any medications, or like that we judge the patient. And if we have any suspicion that he's not fitting into the profile of him and hypertensive bleed, so then if it's a young patient, which he should not be having hypertensive bleed, Then we screen them with the CT angio or MR angiogram. And we were able to find some anomalies also like that. So for the beginners, it is always better to screen rather than to not screen, I think so. So that's how we do screening.
Okay, thank you. Any questions? Professor Kato, do you
Okay,
have comments?
yes. Thank you very much, Professor Hyodo, and also Professor Koyama Sensei, and also the Hari. The excellent lecture of the both. Just I want to ask Hyodo Sensei that in the future, of course, definitely the endovascular is more and more chance for the aneurysm cases. But I think, do you have any suggestion, such as some stent or biological, some healing, some idea in the future, the stent? How do you think? I want to ask both Hyodo and Koyama Sensei.
Who is first?
You first.
Okay. As for the fluid diverter, is now the surface polymer coating. It's something like anti platelet or something. The for pipeline, we can use this kind of fluid diverter. But the thread and also the surface is not yet. But maybe thread X will become. There also is some kind of surface coating, surface coating. But still we have to use some kind of antiplatelet treatment, but maybe reduce. And also the even the subarachnoid hemorrhage, I mean the acute phase, maybe in future we can use the fluid diverter, so that become very convenient, I think.
Thank you. Where was it?
So I think one of the question is a use of web or intra-aneurysmal flow diverters, but I think the last land of the endovascular or craniotomy clipping is maybe a basilar bifurcation large aneurysm or thrombosed large aneurysm. We have no answer at present, but some device like web may be one of the question.
Okay, thank you.
I guess.
Yeah, thanks a lot. So maybe very promising. Ben, you want to ask something? Dr. Ben?
Yes, I'm okay. I think, hello?
Because I saw that the raised hand. No more question from your side?
No more
okay,
question.
Okay.
Sorry,
okay.
I forget to put down
Thank you very much for Hyodo Sensei and Koyama Sensei. And also, as for the ICH, I think someone asked thalamic hemorrhage. So through the ventricle, sometimes we can see the penetration part. The thalamus, the penetrate to the ventricle. So once we can find such a small the hole or some penetrating part, I think sometimes we can evacuate the clot, but sometimes it's sometimes very dangerous. So of course, already the brain has destroyed, so maybe the result is the same, but we can shift to the rehabilitation much earlier once the reduction of the thalamic hemorrhage volume, I think. And also, I discussed, yes?
No, go ahead, please.
Yes, and I discussed already Dr. Hari. I think the most advantage, the endoscopic evacuation of the clot is cerebral hemorrhage, because we can reach the posterior fossa in 5 minutes.
Yes.
So I think it's quite an advantage, but we don't have the evidence. But for the developed countries, I think maybe in the future, the one endoscope and one tube can save the many patients, I think, as early Also, I think clot become the hard once we wait for a while. So maybe we can start as soon as possible. Then the clot is very soft, and also we can leave some part because no need and 100% the removal of the clot for the ICH case. Then we can leave some I think hemorrhage source part. I think in the future maybe we need some evidence, but I think definitely the less invasive for the patient and the short stay of the hospital for the ICH case. Matsui, do you want to say something?
Yes.
Please.
There are two comments. One about Harikiran did a good job.
Thank you.
The thing is that please don't mind being bit categorical on commenting on your evacuation of the hematoma in the putaminal region. You should not be radical in removing a hematoma in the putaminal region. You should leave a medial rim of the hematoma to protect the internal capsule and the medial structures. Radical removal should be avoided. I am sorry if I am too radical in making this statement, but it should be like that. That is one.
Thank you for the advice.
The other thing is about the endovascular thing I already told, and Dr. Yoko already knows that how many aneurysms we are operating in PGI. I am not in PGI at present, but by the time I left, we were operating 450 aneurysms a year, and we were coiling around, say, 80 to 100 aneurysms a year. The same number might be there still. So it's not that the surgical techniques in aneurysm surgeries have gone off or gone down. These are being practiced in India quite a lot. So if there is any hands-on, then it can be, there can be a collaboration with PGI Chandigarh, and Yoko Kato is the best person to have it.
Thank you very much. So I think already the Alexander, he mentioned about how we can educate the younger generation how to do the open surgery. So, but sometimes a recurrent aneurysm. So sometimes we need to do the open surgery. So in that means, I think still we must teach the younger generation.
No, and that is important, Yoko, because the reason is, if they are not operating on the routine aneurysm, and tomorrow if there is a coiled aneurysm comes who needs surgery only and not the coiling again, then it will be extremely difficult. Now, neither the endovascular people are able to do, nor our people are trained to do.
Yes. So we are the same opinion. So Alexander, you have the same opinion?
Sorry. Yes, I completely agree. Yes.
Okay. I think today we had the two less invasive treatment. One is endovascular, the other one is endoscope. So that those two is the future, the treatment for the pathology, I think. So the young generation, the doctors, we learned a lot from them, I think. Yoro sensei, ありがとうございました。
Thank you very much.
No.
Thank you.
Okay. Can I close the session today?
Yes, please.
Okay. So today we are very happy to have Professor Hyodo as a special lecturer and Dr. Kiran as young neurosurgeon lectures. And I hope every young neurosurgeon in Asia learned very, very much tonight. Thank you very much.
Matsuya, thank you very much for your job.
No, thank you, Dr. Good.
Thank you, everyone.
Yoko, you send me your email ID sometimes.
Okay, please. Okay. So
Thank you so much.
Sam and Atik, thank you very much.
Thank you.
Thank you. See you
Thank
next
you.
time.
Bye-bye.
Sure.
小山先生、ありがとうございました。
はい、どうもありがとう
ございました。
Okay, bye.
ありがとうございます。
お疲れ様。
お疲れ様でした。山先生、明日頑張って。
はい。
Arigato gozaimasu to
ありがとうご
everyone.
ざいました。はい。
ありがとうございます。
はい、どうも、どうも、どうも。